Having said that, let's discuss the most common causes of a blister or a vesicle in dermatology. Well, as I said, there are two types mainly of vesicles, flaccid and tense. Let's start with a tense blister. Tense blister. Tense blister is a blister or a bulla that is located in the basement membrane or below, يعني in the dermis. We call it subepidermal bulla, and this is the list of the possible causes of the subepidermal bulla, including bullous pemphigoid, cicatricial pemphigoid, pemphigoid gastationis, dermatitis herpetiformis, linear IgA, and toxic epidermal necrolysis, and etc. While in the interepidermal and the subcorneal bulla, subcorneal means very superficial, just below the corneal layer in the epidermis, and it is very flaccid or very fragile, while the intraepidermal is also into the or within the epidermis, and it is also a flaccid. The most common causes of the subcorneal blister is bullous impetigo. It is an infectious staph. Miliaria crystallina, which is that present because of the heat and sweating, and staphylococcal scalded skin syndrome, SSS syndrome, and this is seen usually in children or pediatric age group. Other is viral vesicles like herpes simplex, herpes, chickenpox, shingles, all can give to an intraepidermal flaccid bulla. Other cause is pemphigus, which is an autoimmune blistering disease that we will discuss now. So in adults, the main group of blistering problem is associated with autoantibody formation. Yani there are antibodies against an antigen in the epidermis and dermis that is causing separation of cells and filling with a fluid. While in children, the most common cause of a vesicle or a blister is genodermatosis, epidermolysis bullosa, associated mainly with mechanical defects and around the basement membrane. يعني, if you were called in the antenatal or in the neonatal unit, a child or a neonate that is just been delivered or born, and you have been called by the on-call pediatrician asking you to come and see a neonate that is having blisters or erosions, because when you have an erosion, it means that it could be a flaccid blister or weak blister that or fragile blister that has ruptured and left only an erosion. So if you are called into the neonatal unit of a newly born baby who has flaccid vesicles or erosions, then you have to think about first infections. The most common infection could be the herpes simplex, could be the varicella or chickenpox. This neonate might have this disease infected while he was in utero, or while passing through the vaginal canal or the uterus and vaginal canal. So he might has this from his mother or her mother. So think about infections first. Take swabs for viral cultures. If you are highly suspicious, start IV antiviral medication like acyclovir, etc. But infection is not the only cause of flaccid, but it is the most common cause of flaccid or tense blisters in neonates. Usually, we need also to rule out genodermatosis, especially the diseases that present with weakness in the collagen or keratin in the skin that leads to formation of a blister or separation of cells and filling with a fluid, especially the epidermolysis bullosa. Epidermolysis bullosa. الآن راح نتكلم عن 3 types of epidermolysis bullosa بعد قليل. So this is a photo of a neonate that has just been born or delivered, and you have been called to assist. You can see this. طبعا this is called annular or ring-like configuration. As you could see, it is like an annular shape, and this is mainly caused by something called IgA bullous dermatosis, one of autoimmune bullous disease. But you need also to rule out herpes simplex in this patient. In this patient, you need to rule out cytomegalovirus, herpes simplex virus, chicken pox أو يسمونها varicella, and also you need to rule out the presence of genodermatosis. We will talk about it now. So how would you diagnose a blister or genodermatosis in children? You need to diagnose genodermatosis, if you are thinking about genodermatosis, is by taking two biopsies, skin biopsy, bunch skin biopsy. The first will be sent for histopathology to see where is the separation and if there is any inflammatory cells and etc. And the second will be sent for electron microscopy. The electron microscopy will detect the actual loss of a keratin or collagen in the tissue, which is being attacked by the there will be lack of this collagen. There will be no antibody, in the epidermis bullosa or in the genodermatosis. There will be defect in the collagen or keratin that will lead to the loss of integrity of cells. الآن راح نتكلم عنها. So how would you diagnose bullous diseases in general in adults or in children? One, routine histopathology. When you take routine histopathology, you send for H&E, hematoxin and eosin. You take from the lesion itself. If this is the blister, you take the biopsy from the vesicle, but from the periphery. So you involve both the blister and the periphery if it was large. But if it is small, take it from the center and send it for histopathology in hematoxin and eosin and formalin 10% to be examined under the microscope. Second, we take another biopsy for immunofluorescence. We don't take it from the lesional skin, we take it from around the lesional skin in this area. Why? Because we will send it for immunofluorescence. Immunofluorescence is a technique that you add specific antibodies to the tissue, and those antibodies will recognize the antigen. Yani those antibodies are directed against known antigens, and they will link together and they will form an immune complex. Then this will fluorescence under light, and I will show you. So if you have fluorescence, it will show what is the pattern and etc. I will show you so you can understand more. Indirect immunofluorescence is from the patient serum. You can take blood and send it for patient serum, and they will tell you what type of antibody he has. And for electron microscopy, if you are thinking about genodermatosis, epidermis bullosa, especially in children. This is direct immunofluorescence. As you could see, that there is a formation of the antigen antibody complex in here, and it is all fluorescent because we added fluorescent material and we have special light for this to detect it. So we know that this is a separation, as you could see, and the separation is where below or at the basement membrane, either at the basement membrane or below the epidermis. So it is not into the epidermis. This is the epidermis and this is dermis. So the separation is, or the physical is at the base membrane or below the epidermis. So let's talk about epidermolysis bullosa. Epidermolysis bullosa is a group of genodermatosis called mechanobullous disease, usually present at birth or in infancy, ranges from localized, relatively mild, with trauma-induced blisters to life-threatening and life-ruining condition. Diagnosis can be based, as I told you, on the family history, because some are autosomal recessive, some are autosomal dominant. Clinical examination, presence of the blisters at the mechanical friction, yani those blisters appear with mild friction. Yani even if you touch the patient or if the patient walks, the blister will appear in his feet. If the patient crawl, yani zahaf, the blisters will appear on his knees and etc. And by skin biopsy and electron microscopy. So we have three types of epidermolysis bullosa. We have the simplex, we have the junctional, and we have the dystrophic types. Simplex, junctional and dystrophic epidermolysis bullosa. So what happens in epidermolysis bullosa simplex? We have problem in the keratin 5 and 14, and those are present in the basal layer of the epidermis. So this will appear as a flaccid blister because the blister is also present in the epidermis. While in junctional, the separation will be in the epidermodermal junction or basement membrane. Dystrophic will appear in the dermis. So, as I told you, let's start with epidermolysis bullosa simplex. Mainly, it is autosomal dominant, and the pathological damage lies within the epidermis. Main defects in the genes coding for keratin 5 and 14 in the basal layer. So this is genetic disease. There is defect in the keratin 5 and 14 genes. Those keratin 5, 14 present in the basal cell layer. So blisters clinically appear as at birth or when the child starts to walk or crawl and develops mild blistering on knees, hands, feet, and other sites or friction. So this is a mild disease. It's not life-threatening. يعني patients might present only, or this child when he start to crawl, لما يبدأ يحبي. Or maybe sometime you can see patients who when they go to Umrah and they start walking and doing الطواف, then they will complain that they develop huge or many blisters in his feet. And when they go to the military, they start to do their training and they walking, a lot of walking, then they develop severe many blisters and frequent blistering on the feet. This could be a sign that this patient has epidermolysis bullosa simplex, and this is usually quickly rupture and heal with no scarring. Any effect of the skin or damage in the skin that is above the basement membrane usually heal with no scarring. This is a picture. As you can see, the flaccid blister, it is already ruptured, and this is a crust, and it is in the feet, and you can see many here and here. What about junctional epidermolysis bullosa? It's autosomal recessive usually, and the base protein or gene which is abnormal is laminin 5 in two types of epidermolysis bullosa, junctional epidermolysis bullosa, and alpha 6 beta 4 integrin in the third. Split at the level of the lamina lucida. Lamina lucida is part of the basement membrane. So the clinical features of junctional epidermolysis bullosa may present at birth, either as blister or often around the nails or road-induced areas. مثل هذه بالضبط. So the patient will be born. You will call to the the neonatal unit or NICU. They will call you saying that this neonate has been just delivered recently and he was born with those erosions or blisters. You think about junctional epidermolysis bullosa and you think about infections as well. So mucous membranes in junctional epidermolysis bullosa may be severely involved. Teeth are commonly abnormal, so this patient will have difficulty in feeding. You need to cooperate and with the pediatric and dietitian for his sake of living. What about the third type and probably the most severe type of epidermolysis bullosa, which is called the dystrophic? It's autosomal dominant or autosomal recessive, could be both, or are associated with defects in type 7 collagen gene. Type 7 collagen is present in the dermis, sublamina, basement membrane. Collagen 7 gene which causes defect in the anchoring fibrils. And one of the most common complications of the junctional epidermolysis bullosa is the development of squamous cell carcinoma in the long-term non-healing scars. So the dominant variance develops in the later infancy or early childhood on friction site and heal with scarring. For junctional epidermolysis bullosa, they heal with scarring. Simplex, they don't heal with scarring, but with junctional, they definitely heal with scarring. And hair and teeth may develop normally in this case, while in junctional, teeth might not develop normally. So this is a picture of the recessive dystrophic epidermolysis bullosa. As you could see here, the blistering And one of the main complication in the recessive, which is the most severe, recessive dystrophic epidermolysis bullosa, is the development of the mitten deformity. Mitten deformity اللي هي نفس المتن الجلوفز اللي تكون 4 أصابع مع بعض وإصبع الحالة يلبسونها في الثلج في أوروبا وفي أمريكا. فمتن ديفورميتي يكون فيه التصاق في الأصابع كلها ال4 ويبقى الإصبع الإبهام لوحده. هذا يسمونها mitten deformity, and you can see the contracture. So this patient will need multidisciplinary approach. They will need pediatric, dietitian, psychiatrist. They will need wound care nurse. They will need plastic surgeon to deal with those fibrosis, and also will need genetic counseling for the parents to make sure that they will not have further children who have this disease, as it is genetic. So as I just told you, it's team management of epidermolysis bullosa, biopsy, prevent friction, occupational therapy, dental care, skilled nursing